Today I'll be speaking about robotic unicompartmental knee replacement. So about 19% of the population globally present with knee arthritis after the age of 45 years. They come with the complaints of pain, disability, and reduced quality of life or reduced activities of daily living. Unicompartmental knee arthroplasty is used in the treatment of isolated femorotibial unicompartmental knee osteoarthritis. That means basically, if the arthritis is localized to a particular region of the knee, then these surgeries will be beneficial for the patient. The proportion of this procedure has been increasing according to the worldwide national registries like the NJR and the Swedish Joint Registry. What are the advantages of the unicompartmental knee arthroplasty? This preserves the natural knee kinematics, which means we preserve all the cruciate and the collateral ligaments. So there's no damage to any soft tissue per se during this procedure, which results in better recovery and improved range of movements following the procedure. As a result, the patients also have a better functional outcome. This reduces the post-operative complications like myocardial complications, cerebrovascular events, thromboembolic events, or any other surgical complications. Also, because we are operating on an isolated area of the knee, we require lesser time compared to a total knee replacement. And as a result of this, there's also lesser blood loss and reduced hospital stay. Most of these patients tend to go home either the same evening, because in UK they have been practiced as daycare surgeries, or they can go home the next day morning. What are the difficulties of this procedure? It is a more challenging and a less forgiving procedure compared to a knee arthroplasty, the reasons of which I'll tell you shortly. This procedure has a steep learning curve, unlike total knee replacement, because adequate positioning of the components, both the femoral and tibial, is quite crucial in this procedure to avoid early complications. There is a considerably high revision rate in manual unicompartmental knee replacement, which is about 7 to 32%, and this is one of the main reasons why there is reduced satisfaction or reduced usage of this procedure. The component malpositioning, malalignment of the limb, and ligament imbalance are the important factors associated with lower survivorship of this procedure. Improving the accuracy of the component positioning alone has been an important topic for most of the surgeons. Here is where the game changer comes in. It's the robot. Robotic assistance plays an important role in reducing the risk of malpositioning of these components, which in turn results in better clinical results and long-term survivorship of the implants. There is plenty of evidence to demonstrate the advantages of a robotic knee replacement. A few of them to mention are the accuracy of implant placement, the ability for inexperienced surgeon to get the implants in the right position when practicing on cadaveric models. Then the midterm survivorship of these operated knees, the patient satisfaction after having a robotic unicompartmental knee replacement, and the early return to sports activities after this procedure, and lastly, achieving the accurate ligament balancing and also the restoring the native joint line. So, as mentioned in the previous talk, there are a few robots we should be aware of. The first robotic unicompartmental knee arthroplasty was done in the USA in 2000. The three types of robot we are aware of are passive, active, and semi-active. So, what is passive robot? So here basically a robot is doing the surgery, but it's basically the surgeon controlling the robot, and the robot is just doing the bone preparation and the implant placement. So all the control is in the surgeon's hand, and the robot doesn't give any feedback in case the surgeon is erring towards malalignment or more towards outliers. The second one is an active robot, where the entire procedure is performed by the robot, though the surgeon is around there. The robot uses a pre-programmed algorithm and defined parameters to do the procedure. However, if the surgeon feels something is going wrong, he can always stop the robot. But there is a high risk of ligament injury or soft tissue damage. The last one is the more ideal one, the semi-active robot, where the surgeon and the robot kind of work together, and this is adjusted and constrained satisfy the surgeon's needs. The one we have in our hospital is a semi-active robot, and I'll briefly describe about the components of this robot. So that is the main robot with a robotic arm, and that is the robotic eyes or the sensors which see where the limb is, and it also assesses where the robot is. So it also has a screen for the surgeon to use when operating. And this is a console which is operated by the Mako product specialist or the MPS, who helps us, kind of release the robot or release the arm, and also keeps guiding us in case he feels that we are erring during the procedure. What are the types of unicompartmental knee replacement? Based on the region worn out, it can either be a medial unicompartmental osteoarthritis, a lateral one, or a patellofemoral one, or a bicompartmental where there's involvement of more than one compartment. So accordingly, based on the region worn out, we can do either a medial UKA, a lateral UKA, a patellofemoral unicompartmental, or a bicompartmental arthroplasty. Now I'll briefly take you through the procedure of unicompartmental knee arthroplasty using a robot. First, as the total knee replacement, we get a 3D CT scan of the patient. And even before the patient is shifted on the table, we do a few assessments and look into a few parameters. So the top images are for assessment of the tibial implant, and the bottom images are for the assessment of femoral implant. So the first image, we can see that there is the joint line, and we place our implant such that it is just about around 3 millimeters proud of the joint line. In the second image, we can see we are already matching the implant in the anteroposterior axis so that the implant is not proud. And here we can see that we have placed the implant just adjacent to the tibial eminence such that it is not impinging on the attachment of the ACL. So this preserves our cruciate ligament. The next image shows our contour, the implant placed along the contour of the tibia. So as a result of this, we have perfect placement of the implant. And secondly, we already know the size of the implant even before we open the joint, which is the beauty of the robot. And the last image is showing the attachment of the PCL, which is completely left free, and the implant is nowhere close to the arch there, which means the posterior cruciate is safe as well. The images below here are for the femoral implant placement. In this image, we can see that about 75% of the bone is covered by implant, which is the desired amount that needs to be covered. The next image is showing the implant being proud beyond the cortex, which is exactly 1 millimeter distally and 1 millimeter posteriorly, and it's aligned such that it's absolutely parallel to the bone. In the other image, we can see the rotation of the implant has been adjusted such that it's along the contour of the femur. And the last one is the lateralization of the implant. We can see that it's almost bang center there, almost central to the posterior condyle. So all these adjustments are done even before the patient goes on table, which means we are thoroughly prepared, and when we open the joint, we don't see any surprises. So this is an image of how we set up the patient and put in the arrays as mentioned in the previous talk. And then also we have the checkpoints for the tibia and femur. So having these arrays and the checkpoint gives the robot a 3D alignment of the leg, and no matter what position we move it in or rotate, the robot can adjust accordingly. So here's a picture of the incision, which is almost about just 60% of the incision compared to the incision we give for a total knee arthroplasty. And these are the arrays being attached and tightened. Following this, we go to the bone registration of the femur and tibia. So we have 40 points on the femur based on which side we are operating. If you are doing only the medial side, the points are shown only on the medial side. If it's the lateral side, it's shown only on the lateral side. So this is an example of a medial UKA. So we have 40 points on the femur and 40 points on the medial side of the tibia. So once we mark these corresponding pointers on the bone, the robot now knows where the limb is, where the bone is, and how much of cartilage is there, and how the bones are aligned. So it the robotic limb becomes in sync with the sensors that are placed at a distance. Next, we look for ligament assessment, the laxity or the tightness of the ligament. So we take the knee through different range of movements. Usually, the desirable movement would be about 15 to 30 degrees. So say 15, 30, 45, 90, and all the way to 120. And then we assess the ligament tightness or laxity. So if it is lax, it's shown as blue, and it's along the positive axis. If it is tight, it will be shown as orange and along the negative axis. So yeah, this is an example where it is lax during extension and starts becoming tight during flexion. So based on that, we can alter the implants, both the femur and tibia. We can flex it or extend it. We can give it a varus valgus, or we can also give it rotations. So we try to bring all these bar charts in the blue region, that's in the positive region, and you can see it is accurate this in millimeters, so that's 0, 1, and 2. Usually we try to keep it between 1 and 1.5 because we do want some breathing space for the implant, but not be too lax because that will lead to implant failure. And we should make sure that all the orange bars are corrected because this will be quite crucial for the functional outcome and the patient satisfaction. So once we do that, we notice that all the bars have come to blue as shown there. Now again we go back and map the cartilage. This is the second time we are doing it to make sure the anterior flange of the implant, that the femur, is not proud, because this is quite important for the tracking of the patella. If the implant is quite proud, it's basically metal rubbing on the cartilage and the patient will end up with anterior knee pain. So we again go make sure the implant is well buried within the cartilage and not proud outside. And the other image is assessing the tracking of the femur on tibia, and we rotate the implant such that we have a straight alignment of the tibia on the femur. Basically, when the femur moves on the tibia, we don't want any misalignment. We want it to move straight. And again, when we look in the axial section, that is the picture of the femoral implant and the tibial tray there. So all these are being done even before we go to the bone preparation. So the moment we are entering bone preparation, we know the position of the implants that are going to be placed in. The next step is the bone preparation, where we use a burr to remove the excess bone. First, we prepare the femur. As seen in this picture, we can notice the region to be burred off is seen in green color, and as the burr starts moving, the excessive bone disappears and starts appearing white. In case we remove excessive bone, that starts appearing red. But the robot is so intelligent that it doesn't allow us to go any more than 0.5 millimeters within the bone. So once that is, and also you can see with the burr there is a high flow water jet. This is basically to cool off the heating bone, because the heat generated by this burr can cause bone necrosis, and that can lead to early infection. Next is the tibial preparation, where we prepare the tibial tray with a saw and the ridge with a burr. And after this, we put trial implants in, which are already suggested by the robot, and then we reassess the ligament laxity and the alignment. And once we are satisfied with all this, we move on to the cementation and actually place the actual implant, and that's pretty much it. These are a few examples of the procedures we have done for robotic unicompartmental knee replacement. So in this X-ray, you can see that the arthritis was localized to the medial side, and we have opened it beautifully. And this is a lateral image of the same patient. So you can see the nice contour of the implant along the bone. So this is another case where there was significant medial compartment osteoarthritis, and that has been well opened up in this X-ray. That's a lateral image again. A third patient X-ray. So concluding the talk, it's the unicompartmental knee replacement using a robot is an effective and a safe surgical procedure. It significantly reduces the complication rate intraoperatively and postoperatively. This results in improved knee function compared to a conventional knee arthroplasty. Robotics will simply become a valuable supplement for surgeons to simplify the operative process and make individual specific plans in the future. Here are a couple of pictures of me with my clinical leads in Aberdeen, UK, who introduced me to the world of robotics and trained me in robotic hip and knee arthroplasty. I thank Dr. Sharan Patil sir for giving me this opportunity to talk to all of you, and I would also like to thank my senior colleague Dr. Ravi Kumar for his support since I joined this institute. I'll try my best and make you proud, sir. And last but not the least, I thank each and every one of you for making time amongst your busy schedule, coming here and letting us demonstrate the wonderful work we do in this hospital. Thank you.